Kia ora koutou, ko Lucinda Thatcher aho. Good evening, everyone. My name is Lucinda Thatcher, and I am your host this evening, along with Gary Nixon, my chat coordinator. Welcome to our midwinter special on the bare bones of flaming joints. Over the next hour or so, we will be exploring the world of rheumatology and inflammatory arthropathy, an area not often covered in webinars. This evening's session is run by the Section of Rural Health, the Department of General Practice at the University of Otago, and is supported by the Rural Hospital Medicine Division of the Royal New Zealand College of General Practitioners and endorsed for 1 hour of CME. If you'd like me to lodge your CME points for this evening's session, please complete the evaluation form at the end and put your medical council number there. Just recognise that this offer is only available for the live session. We appreciate all feedback, positive and constructive, and as always, look for further ideas for future webinars. Our speaker this evening is Associate Professor of Medicine, Will Taylor, who is a consultant rheumatologist working in the Hutt Valley, Tairāwhiti, and at the Wakefield Specialist Centre. I would like to take this opportunity to say thank you to Will on behalf of all our rural practitioners for your time and expertise this evening. We would recommend you have a pen and paper, pretty old school, or some form of iNote to test yourself as we go through tonight's webinar. If you have a question, please put it in the chat, remembering the first step to receiving an answer is being brave enough to ask the question. So on that slightly, hopefully, inspirational note, I will hand over to Will.
Kia ora tātou. Thank you very much, Lucinda, and it's a great pleasure to be talking about a subject that is kind of bread and butter in my day job as a rheumatologist. So I'll try and advance to the next slide, if it'll let me. So we're going to talk about inflammatory arthritis, and I have circulated a few questions to think about. Hopefully some of you may have thought about them already, but if not, we'll think about them through the course of the next hour or so. And obviously I'm going to be providing some of the answers, but they're not always the answer, and I'm happy to take questions and discussion at any time. So we're going to focus initially, at least, on some cases. And the first case is a 23-year-old woman who comes to see you with a 3-month history of painful stiff fingers in her hands and feet, particularly, especially worse in the mornings and on cold days. And she says that there has been some swelling and that she's noticed that her rings are a bit tight. I'm just going to make the pictures of you all smaller. But when you examine her, there's not really very much to find that's abnormal apart from tenderness of the joints that are sore. Otherwise, there's not much abnormal to see on examination. You do a blood test, and she has a slightly elevated CRP, 12, strongly positive rheumatoid factor, weakly to moderately positive ANA test, and you do some x-rays of her hands and feet, which are normal. So this is pretty barn door rheumatoid arthritis, although some people, some authorities and guidelines require objective evidence of swelling, like the examining physician has to see joint swelling, which can be tricky in the early stages because often the swelling is intermittent and may not necessarily be present when she visits you in your surgery. So, but the other clues here are the slightly raised inflammatory marker and the abnormal autoimmune serology. So the first question is, what are these? What do I mean by these 3 clues to the diagnosis of rheumatoid arthritis? What sort of gives it away and makes it pretty characteristic and typical?
So at this point, you can feel free to just jot some quick notes down on that pen and paper. Test yourselves.
So I'll pause just for sort of 5 seconds, because otherwise we'll run out of time if I pause too much. Yeah. But there are quite a few clues, really. So One particularly characteristic feature of rheumatoid arthritis is that the MTP joints are involved, and there are not very many other inflammatory arthritic conditions that have inflammation of the MTP joints, particularly the lesser toes. And so a positive MTP squeeze test is often recommended as a useful clue to involvement of these joints. The second thing is very prolonged or fairly prolonged morning stiffness. Now, morning stiffness is a tricky feature to evaluate because it's pretty common in just about any kind of musculoskeletal condition, including trauma or osteoarthritis, or just having been to the gym the day before. And so the kind of the clue to what rheumatologists like to think of as inflammatory morning stiffness is prolonged morning stiffness, at least 30 minutes and often much longer. So the patient will describe that they're very stiff when they get out of bed in the morning, and it doesn't kind of go away often until mid-morning. And that can be distinguished from the brief sort of morning stiffness that resolves after a hot shower, or the stiffness that never goes away. So it's actually not, strictly speaking, morning stiffness, it's just all-day stiffness. So that lack of diurnal variation is another point away from rheumatoid arthritis, really. And then the third clue is that rheumatoid arthritis is very much an autoimmune disease characterized by abnormal antibodies, which can be measured. And the commonest ones are rheumatoid factor and CCP. There are a number of other sort of research tools that show up other autoantibodies, but these are the ones that have come into general clinical practice. Now, the ANA test is often positive in rheumatoid arthritis, but it's not very specific to rheumatoid arthritis. So I do mention it there, but it's not a particularly useful test in diagnosing rheumatoid arthritis, although it's often abnormally positive. And then there are a bunch of other clues, particularly extra-articular clues, that can make it very clear that this is rheumatoid arthritis. So things like interstitial lung disease, ocular pathology like very dry eyes or episcleritis, rheumatoid nodules, which are puzzling, and we might talk a bit about that in another slide, and nail fold vasculitis. Extra-articular features tend to occur in people with pretty bad rheumatoid arthritis or fairly prolonged rheumatoid arthritis, so it's normally pretty obvious from their joint disease that they've got rheumatoid arthritis even before they've developed these extra-articular symptoms. So I don't see any questions on the chat, so I'll just kind of keep going if that's okay.
Yeah, sure do. Yep, go for it, Will.
Now we could tweak this particular case a little bit. This time the young woman presents again with the same history and the same examination findings, but now her CRP is only just a little bit raised. The rheumatoid factor test is negative. The CCP antibody test is negative. She has a weekly positive ANA test, and again, plain X-rays of the hands and feet are normal. In this particular instance, we don't really have that much objective evidence. Seronegative rheumatoid arthritis, which is relatively common, is much more difficult to diagnose than seropositive rheumatoid arthritis. And partly that's because of the lack of objective pathology, like the abnormal serology. Probably about 30% of people with rheumatoid arthritis are seronegative for the rheumatoid factor, and probably about 20% are seronegative for CCP antibodies. So they do form quite a sizable group of patients. And one common approach to try to nail down the existence of actual joint inflammation is imaging. So imaging can be very helpful to identify subclinical inflammation of joints, where the patient's presenting with clinically suspect arthralgia, or you don't see joint swelling on examination in the clinic, and their serology is not particularly diagnostic, then MRI or ultrasound is quite helpful. So MRI can identify erosions much earlier than plain X-rays. Bone marrow edema, which is not exactly edema, but it's a cellular infiltrate adjacent to the joints in the bone, which represents inflammation in the joint. And it's called edema because it shines brightly with a water signal on MRI. And then synovitis, which often shows up better with gadolinium contrast. So you can directly see the pathology of interest on MRI. So it's a very helpful and very sensitive test. People who complain of joint pain who have a normal MRI scan are very unlikely to have rheumatoid arthritis. And the other thing that's helpful with MRI is that bone marrow edema is associated with a greater risk of subsequent erosion, so it has some prognostic value as well. Now, MRI is a bit difficult to arrange often, and it's quite expensive. And I'm guessing in some places it requires quite a bit of travelling. So ultrasound has become quite a useful substitute. Ultrasound can identify erosions and synovitis quite well, but it doesn't pick up bone marrow edema. That's only visible on an MRI scan. But the biggest advantage of ultrasound is that it can be done by the treating clinician in the clinic, enabling treatment decisions to be made there and then. And I'm aware that a lot of rural doctors, rural hospital specialists perform ultrasound for various reasons, not necessarily musculoskeletal ultrasound, but it may be something that could be learned. And it's certainly the case for many rheumatologists, especially young training rheumatologists now learn ultrasound almost as part of their training. I'm a bit older and not very anatomically minded, so it never kind of rubbed off on me, I'm afraid. But yeah, ultrasound's a useful tool in the clinic. Okay, so the next case is a...
I might just quickly, Will, just a couple of things I wanted to highlight was last night when we were speaking, we were talking about MRI. And MRI, you wouldn't do an MRI on everyone. It would be more utilised in those that there was clinical uncertainty. Is that
definitely correct? Yeah. And it's, you know, because making a diagnosis of rheumatoid arthritis does tend to lead to recommending a bunch of potentially toxic drugs. So you don't want to come to making a diagnosis on, well, put it another way, you want to have a pretty firm platform for making a diagnosis of rheumatoid arthritis, not only because of treatment implications, but insurance, stigma, the sort of things it does to someone who's told that they've got a chronic disease that's never kind of go away. You know, there's a lot to take in when you diagnose somebody with rheumatoid arthritis. So you want to be reasonably clear. And as somebody who's seronegative and doesn't have objective swelling that you can see, I think it's helpful to have a more secure footing using imaging techniques.
Fantastic.
But on the other hand, somebody who's obviously seronegative, seropositive, has a raised CRP, looks like rheumatoid arthritis, and they've got the joint swelling, it's a bit superfluous to go on and do MRI in those cases.
I'm wondering when is the best time to have that quick synopsis of of the rheumatology, the rheumatoid serology sort of stuff, rheumatological serology, when do you reckon would be the best time to have a quick discussion around the rheumatoid factor and just mentioning about the ANAs and what's a positive ANA?
Right. Yeah, ANA is a particularly difficult blood test, actually. So it's really associated with lupus, SLE, and some other multi-system disorders like scleroderma or idiopathic myositis. When I said it's often positive in rheumatoid arthritis, it doesn't really carry any diagnostic weight, though. And the other point is that almost any autoimmune disorder, including Hashimoto's thyroiditis, can give you a positive ANA test. It's also present in a lot of completely normal people. So at least 5% of healthy blood donors have a positive ANA test. And when I say positive, I mean what the laboratory report is positive, which is generally at least 1 in 80 titer. So the ANA test should be regarded as a screening test. If it's negative, then it's very unlikely that they've got lupus or some other kind of autoimmune connective tissue disorder. When it's positive, you're not really sure, but there are a bunch of other autoantibody tests called the ENA panel and the double-stranded DNA panel, double-stranded DNA antibody test, which are much more specific and don't hardly ever give false positives. So I think, I've mentioned ANA test in those two cases because it's often presented like that from a GP referral. ANA tests are commonly done, but very rarely give you useful information unless you clinically suspect a disease like lupus. And joint pain by itself is not really sufficient to strongly suspect lupus, in my view. There's almost always some other thing like frequent mouth ulcers or hematological abnormalities or a rash or photosensitivity or something like that. So I'm not sure whether that answers your question or not, but rheumatoid factor test and CCP antibody test, much more useful in people who have peripheral inflammatory joint disease.
And will the level of the titer in the ANA that gets a rheumatologist excited is? Yeah,
well, that's a bit of a kind of a trick question. I know you asked me that yesterday, and I gave you a number.
It's not 1 in 80, is it?
No, well, no, but it's not so much the titer actually; it's all the other things that go along with it. So, you can get people with very high titers who are absolutely normal, and you can get people with very low titers that have definite lupus, including renal disease. So the level of the titer, again, doesn't tell you that much either, really.
Right, good. And then the other one was about the pattern, which you basically disregard because that always gets reported on our reports.
Yeah. So that's a traditional immunological thing too, and the only pattern that's worth taking any notice of is the centromere pattern, because that's quite closely associated with limited scleroderma. So people who present with Raynaud's out of the blue ought to have an ANA test, and if they have a centromere pattern, then that's a definite clue to their Raynaud's being secondary to scleroderma or systemic sclerosis, and those people definitely warrant referral.
Brilliant. Thank you, Will. Gary, okay. Anything from your end?
No, there's nothing at the moment there, Lucinda, but it's really good stuff, Will.
Thanks, okay. Gary. All right, so we're going to move to an older age group now, a 72-year-old woman who's presenting with a relatively short history this time too, 2-week history of painful stiff fingers, hand and shoulders, particularly in the mornings on cold days, very stiff and sore with marked difficulty getting out of bed in the mornings. And apart from stiff shoulders and obviously in the clinic room difficulty moving about, there's not a lot to see on examination. And she has quite a high CRP level of 60, normal rheumatoid factor, again, weekly positive ANA test, the ubiquitous ANA test. Now this person was diagnosed with polymyalgia rheumatica, not completely unreasonably. She's in that age group. She's got marked morning stiffness. She's got shoulder girdle pain and stiffness. She's got a high CRP, and she responds really well to prednisone. So everyone's happy that that's what's going on. But 4 years later, she's still on 10 milligrams of prednisone, and she has ongoing finger pain and swelling, and now also her feet are painful, and she's got swollen knees. And I present this case because particularly in the elderly, rheumatoid arthritis can present very similarly to polymyalgia rheumatica, and it can be quite confusing. So one common reason for what looks like PMR initially that doesn't sort of track along what you expect for someone with PMR, one reason for that is that they've actually got rheumatoid arthritis instead. So this is another kind of presentation of rheumatoid arthritis. And I should mention too, actually, that although we use this term rheumatoid arthritis as if it kind of covers everything and it's just one kind of unitary disease, it most likely isn't. But we just haven't figured out satisfactory ways of phenotyping particular types of rheumatoid arthritis, I would say, which is probably it's probably a lot more complicated than we think, and hopefully genetics or something like that will help clarify things. But this is another way this is another mode of presentation for rheumatoid arthritis. So people with PMR look like PMR. It's very useful to do a rheumatoid factor test and a CCP antibody test early on, because if they're raised, if they possess those antibodies, then that's a clue that they might not turn out to be straightforward PMR. And another kind of mimicking condition is gout. So this is a 68-year-old man who has a very long history of painful stiff fingers, hands and feet. Initially, his symptoms were quite intermittent, but now they're a lot more constant, worse in the mornings and on cold days. And more recently, he's developed nodules around the elbows and fingers. And he's got obviously swollen small joints and nodules. He's got a high CRP, and he's seronegative for rheumatoid factor and CCP. And this could be gout. This could be rheumatoid arthritis. It's not clear. And nodules particularly can be confusing. So I've got pictures here. One of these pictures has rheumatoid nodules, and the other one has gouty tophi. And I asked Lucinda last night to pick the one that she thought had gout, and she
Got it wrong.
Get the right one.
No, I got it wrong.
But I can tell you that this person here on the left has rheumatoid arthritis, and this person on the right has gout. And gout really is an arthropathy because it causes damage to joints, and the nature of that damage can involve erosions that can look very much like rheumatoid arthritis, and it can lead to deformities that look like rheumatoid arthritis.
Mm.
But in terms of nodules, rheumatoid nodules are typically much firmer than gout nodules, and they don't discharge, whereas gouty tophus, particularly in elderly women on diuretics, often have quite large tophi over their fingers that discharge can become infected. But in tricky cases, it may be necessary to do a needle biopsy or an excision of one of these nodules to be absolutely sure what's going on. These days, there's another very useful non-invasive imaging technique called dual energy CT, which can resolve, color code different chemicals. So you can actually light up urate deposition on a DECT scan, and that can be quite a useful pointer towards gout in someone who you don't necessarily want to be sticking needles into. So that leads me to the next question, which is about gout. I mean, this presentation is kind of focused a lot on rheumatoid arthritis, actually, but the title is inflammatory arthritis, so we'll talk about other diseases a bit too. So this section is a bit about gout, and yeah, have a think about the various myths that you've come across regarding gout management. And I can tell you that there's more than 3. So these are just some of the ones that popped into my mind. We're taught never to start urate-lowering therapy during an attack of gout. A fixed dose, 300 milligrams, is usually enough of allopurinol. Getting serum urate into the normal range is enough to control gout. Most patients are adherent to gout treatment. That's probably not so much a myth as sort of wishful thinking, I suppose. Allopurinol will fix gout fast, and gout is not a kind of arthritis. I don't think doctors are confused by that last one, but patients certainly are. They get quite surprised when you tell them that the gout is a kind of arthritis. So the first one about never starting urate-lowering therapy, this has actually been studied relatively robustly, and it doesn't seem to make actually any difference. The problem with allopurinol commencement or increasing the dose of allopurinol is that it always makes gout worse no matter what phase of treatment you started in, whether it's during the attack or after the attack's finished or a few months later. It always induces an unstable period of time when gout is when the crystals and the urate in the blood have been mobilized. So yeah, you just have to kind of suck it up really, and start urate-lowering therapy in combination with prophylactic drugs like NSAIDs or colchicine or sometimes prednisone. The second myth regarding the dosage of allopurinol, there's an enormous range of effective doses, and 300 milligrams may be quite adequate for many people, but so might a smaller dose, but often larger doses required. And the best way of preventing gout is treating to a target urate level, and that target is significantly less than the upper limit of normal, which is around about 0.42. So for most people, you need to achieve a target of less than 0.36 millimoles per litre. And for tophaceous disease, where there's a bigger total body urate load, they ought to have an even lower level of target in order to shrink tophi in their lifetime. Because we remember that that the fundamental problem with in gouty patients or patients with gout is that their kidneys don't excrete urate efficiently, and the only way of getting rid of urate is for them to excrete it through their kidneys. So it takes a long time for total body stores of urate to be sufficiently depleted such that they don't form crystals anymore. So it's a long-term project starting allopurinol therapy, and it can take up to 6 months to a year before things are sort of stable. And it's really important to warn patients about that period of instability, so they don't think that you're poisoning them with this horrible drug that's making the gout worse, which it probably will do. And yeah. So we know that most patients are not adherent to any of the drugs that we prescribe for any condition, actually, but gout is particularly bad, and that's partly because it tends to make things worse when it's started. So why would you bother taking a drug that seems to be making things worse? But adherence does tend to get better with time, and patients. There've been a nice study from Norway that shows that patients' beliefs in the effectiveness of their gout treatment improves over time. So with the passage of time and the direct experience that things are getting better, then adherence improves. So I'll move to the next slide, although I'll just pause if anybody has questions about gout management, because it's a pretty common disorder.
I just wanted to make a comment around the use of colchicine, and in terms of the dosing. It's not quite so new anymore, but we used to use much higher doses of colchicine, and that's been changed. We no longer use it till we get diarrhea and hold people back then. And also in terms of the dosing of colchicine as a prophylactic agent and how long you use it for, Will?
1 or 2 tablets a day and sometimes, one tablet a day is often enough. 6 months, so it's a good long time.
Yes, absolutely. As you titrate up the allopurinol, sort of 100 mgs monthly.
Yeah,
And
that's the other point, I guess, to make about the up titration. Starting at a low dose has 2 advantages, really. One is that the incidence of the allopurinol hypersensitivity syndrome is less if you start at a low dose. And also the second thing is that the post-initiation flare rate seems to be less if you start at a low dose too, and sort of gradually increase it. So the allopurinol hypersensitivity syndrome is a pretty scary disorder. People get very sick, ICU, ventilation, even death. And if you have a patient who has that, you never really want to use allopurinol ever again, actually. But fortunately, it's rare, and it can be, as I say, the incidence can be reduced by starting low and gradually increasing. And the choice of that starting dose often can be guided by the kidney function. So for people with renal impairment, starting at a lower dose is probably a good idea. And there's some algorithms around that quantifies that. I don't have the numbers in my head right at the moment.
it's all in the New Zealand formulary. Nicely done for us.
Yeah. Okay. So
do you want to ask a question, Gary?
Yeah, there's a couple of questions there. Although I thought you were going to say, when you're talking about the 3 myths, I thought one of the myths of gout was that skinny white guys from down south don't get it. But I know in fact that's not true.
Yeah, like I said, there's loads of myths, and that, I mean, that gout is quite an interesting condition from a sort of social anthropology perspective too. There's so much in the literature, in media, and just in the community, the stigma associated with gout being a disease of obese people who drink loads of red wine and have a lot of fun and pay for it. But that's clearly not true.
Well, Jack had one question about using intra-articular steroids in general practice for patients who get an acute flare of gout.
So is the question that is it a good thing to do? Yes, it is a good thing to do. Yep. And there are intra-articular steroids are very effective in treating an attack of gout. And also it can be a good opportunity if you aspirate some synovial fluid at the same time, you can definitively confirm that this is gout. Now, when it's affecting the great toe joint, which is the sort of the most common presentation, that's not always that easy. Sticking a needle into a big toe joint is sort of the last thing a patient with a really, really painful toe wants you to do, and so it's not that common. But for other larger joints like ankles or knees, it's really good.
Okay, thanks. Well, I've just got one other question myself. I mean, frequently we will see patients when they're on the ward for some other condition and they're on a bit of allopurinol for gout. Should we be using that as an opportunistic time to check the uric acid and titrate their allopurinol? Because I certainly get the impression that allopurinol is not titrated in the way that it should be.
Yeah, and there's a lot of research and data to back up that perception, Gary, that you're quite right. Allopurinol is not typically titrated up to target. And gout attacks are more common in hospitalised patients with gout. Coming into hospital is a risk for their gout to be worse, and that possibly partly due to dehydration or sepsis or sometimes being nilled by mouth and missing their doses of allopurinol that can precipitate gout. But yeah, I think that it's a useful time to review their gout management and giving some advice around up titration.
It is one of those medicines where you have the opportunity to overcome clinical inertia, isn't it? Great, thank you, Will.
Okay, now next patient illustrates another set of conditions. So this is a youngish man with a 2-year history of intermittent pain and swelling of the left knee, and now swelling of one finger and a couple of toes. And he has a itchy kind of rash in his natal cleft, which he hasn't really paid that much attention to, but you've noticed it as a doctor who does thorough examinations. And he has a raised CRP of 45, and he's seronegative for rheumatoid factor and CCP, and his X-rays are normal. So this is a different kind of inflammatory arthritis, and this is a picture of what dactylitis looks like. So this third toe and this fourth toe are just like little sausages. That's why they're called sausage digits sometimes, where the whole toe is swollen. It can affect the fingers too, but it's probably more common in toes actually. And this particular feature is relatively pathognomonic for spondyloarthropathies. It doesn't occur in rheumatoid arthritis, and it's very rare in other disorders. So when you see dactylitis, it gives you a strong hint towards a spondyloarthropathy type disorder, and there are a bunch of those conditions. One is psoriatic arthritis, which is probably the commonest association with dactylitis, but it can also occur in reactive arthritis, ankylosing spondylitis, or inflammatory bowel disease associated arthritis, but most commonly with psoriatic arthritis. So the next question, so that's just me saying it again. So the next question to think about here is what distinguishes spondyloarthropathies from rheumatoid arthritis. This is the biggest other group of immune-mediated inflammatory arthritis that we see, and it's quite different from rheumatoid arthritis. Although they're both immune-mediated disorders, the problem in rheumatoid arthritis is the adaptive immune system with all these antibodies, whereas in spondyloarthropathies, the problem is the innate immune system. There are no abnormal antibodies that we can test for in psoriatic arthritis or ankylosing spondylitis. The only abnormal blood test that occurs really is, and this doesn't always happen either, is a acute phase marker like CRP goes up. So what distinguishes, so some of these things are, well, firstly, the name gives a big clue. So spond is a sort of a Greek word, I think it's Greek, for spine, and axial disease is much more common in these conditions than it is in rheumatoid arthritis. And in fact, low back pain is never a feature of rheumatoid arthritis. So when you see someone with back pain that you think might be inflammatory in nature, don't ever do a rheumatoid factor test. And it's a waste of time. Rheumatoid factor test and CCP antibodies, all those antibody tests are for people with peripheral inflammatory joint disease, not the spine. Having said that, rheumatoid arthritis can affect the neck, so particularly the atlantoaxial joint, but that tends to be a late feature and it's not really part of the diagnosis often. And the other point is that spondyloarthropathy conditions are often just a few joints. That's not always true either, but so some people with psoriatic arthritis can get a polyarthritis that looks a bit like rheumatoid, but most often it's oligoarticular, so just a few joints, often lower limb joints like knees or hips. Third thing is this concept of entheses, which has become quite important over the last probably 20 or 30 years, that it's recognised that Achilles tendonitis or plantar fasciitis occurs much more often in spondyloarthropathy conditions. And there's quite a bit of imaging evidence and some sort of pathological studies that show these bony attachments of ligament and tendon or capsule, that junction with the bone is a particular site of inflammation for people with spondyloarthropathies. And you can imagine that why this is the case in ankylosing spondylitis, because the sacroiliac joints are just masses of very strong ligaments holding together the base of the spine to the pelvic bones under quite a lot of force from the long lever of the spine. So there are loads of ligaments throughout the spine and especially around the sacroiliac joints, which is kind of probably why that the sacroiliitis is so pathognomonic for ankylosing spondylitis. And then there are some peculiar extra-articular features that don't occur in rheumatoid arthritis. So the eyes can be affected by rheumatoid arthritis, but it's episcleritis and sicca or dry eyes rather than anterior uveitis. Anterior uveitis is much more associated with reactive arthritis or psoriatic arthritis or ankylosing spondylitis. Any of those conditions, you get anterior uveitis, and it's probably again where the iris fibers join some kind of harder structure to kind of pull against, kind of analogous, I guess, to the enthesis. And I haven't mentioned it here, but aortic root and the aortic valve can be damaged or inflamed in ankylosing spondylitis. And again, that can be seen as a sort of a enthesitis of the heart, if you want to kind of stretch the analogy a bit. The last thing is that rheumatoid arthritis is not associated with the HLA-B27 gene, whereas almost everyone with ankylosing spondylitis will have that gene. About 95% of AS patients have that gene. But it's not an amazingly useful diagnostic test for AS actually, because probably at least 8 to 10 to 14% of the normal healthy population have the HLA-B27 gene. So it's not very specific. And because back pain is so, ubiquitous, if you did an HLA-B27 test on every person that you saw with back pain, then you would really over-identify people, and we would be swamped in rheumatology clinics with patients with mechanical back pain. So the most useful diagnostic test actually shall I just pause there, Lucinda? Is there something you wanted to ask me,
No,
or
no.
shall I just move on?
Yep, keep going, Will. Yep.
So, the most useful test for a spondyloarthropathy condition is imaging, particularly ankylosing spondylitis. So plain X-rays of the sacroiliac joints can show signs of sacroiliitis, particularly in later stages. And for people who are presenting within the first few years of symptoms, MRI is very useful. So imaging is a kind of a cornerstone for diagnosis of AS. For peripheral joint disease like reactive arthritis or psoriatic arthritis, it's the clinical pattern that makes the diagnosis much more than any investigation. So having a raised CRP may be helpful, but there are no antibody tests that you can do to clinch the diagnosis. It's based on clinical judgment and the pattern of symptoms.
Well, in terms of a reactive arthritis, is that just going to be say if it's related to chlamydia or a gastro infection, will that just be a short-lived condition, or does that tend to moulder on?
My kind of rule of thumb is that about a third resolve over a short time, like 1 to 3 months. Then there's another third that it moulders on for a longer period of time, maybe a year or so. And then there's another third where it seems to be a chronic condition and it keeps kind of coming and going.
Okay.
I don't know. There used to be a vogue for testing the HAP27 gene in people with reactive arthritis because it may predict a longer disease course. But yeah, I don't know that it's that accurate, and just watching and waiting seems fair to me. There are some drugs, DMARD type drugs that are used in chronic reactive arthritis.
Okay. In the essence of time, we'll move on.
Yeah. So now we're going to talk. We're sort of circling back to our first case, the young woman who had a pretty clear-cut presentation with rheumatoid arthritis, and we're talking about in the last segment management issues. So that brings me to the fourth question, which is about methotrexate. Why is methotrexate the most favourite drug of rheumatologists? Not sure whether that's totally grammatically correct, actually, but you get what I mean. So just pause for a couple of seconds, and I'll tell you why I like methotrexate a lot. So it's broad. One of the most important reasons is that it kind of works for many different autoimmune and immune-mediated diseases. That includes psoriasis, psoriatic arthritis, lupus, rheumatoid arthritis. It's been used for treating progressive multiple sclerosis, not amazingly well, but has been used. Inflammatory bowel disease, inflammatory eye disease, almost any kind of inflammatory sarcoidosis. Methotrexate is a useful agent, not always shown in double-blind placebo-controlled trials, actually, but still many of those diseases don't lend themselves very well to being evaluated in that way. But methotrexate has a good reputation for lots of immune-mediated conditions. And so rheumatologists use it a lot, and then they get kind of used to it and familiar with it, so they use it more. It also has a reasonably good toxicity profile if it's used in weekly low-dose regimes, by which I mean less than 20 or 30 milligrams a week. And if you just compare that to a typical cycle of methotrexate and cancer chemotherapy, high-dose cancer chemotherapy, it's almost a couple of orders of magnitude different. And so the toxicity that you see with that dosing is different from the toxicity that you see with low-dose oral methotrexate given weekly. So, yeah, probably about 80% of patients that we start on methotrexate continue with it, and most stop it because of toxicity issues, often nausea. It's also pretty easy to take in that it's just once a week, and patients often are quite surprised that, quite glad that they don't have to take a drug every day, and a weekly dosing. As long as they've kind of got a regular schedule around that, it seems to work quite well. So that's methotrexate. You'll have patients for sure on methotrexate for one reason or another. And the objects of treating rheumatoid arthritis are kind of twofold. The first one is obviously to make the patient feel better, and that involves, relieving the symptoms of joint pain and stiffness and swelling, hopefully making them able to do their day-to-day lives more easily and without discomfort. But the second really important thing that we want to try and do is to prevent damage from occurring in the joints, because we know that rheumatoid arthritis has this propensity to cause quite marked destructive joint damage. And this is an X-ray of a lady with that kind of problem, and you can see sort of normalish looking PIP joints, but these MCP joints are effectively destroyed. There's no joint space. This one's just sort of falling off its peg, and in the wrist there isn't one anymore, and all of these kind of moth-eaten looking darker spaces are erosions. And rheumatoid arthritis has this propensity to erode away cartilage and then the underlying bone, which unfortunately is not easy, or actually not possible with current technology to repair. And so once the damage is done, there's kind of no going back. And so trying to prevent the damage in the first place is the sort of the mantra of treating rheumatoid arthritis.
Great, that sounds good.
Yeah, and the way that we do that is, I'll ask you, how do we do that? So what are the three most important treatment strategies to effectively manage rheumatoid arthritis, given those two objectives?
If we just put that straight up, Will, because we're running tight on time now.
Yep. So the first thing is to start before the damage occurs. So that means starting pretty early. And also, this does seem to be it does seem to be easier to control the disease when the total volume of inflamed tissue in the joints is sort of smaller rather than larger. And there's quite a lot of evidence to show that starting early, like within the first 6 weeks or so, after symptoms or referral is helpful. And I tend to ask GPs now to start methotrexate when I receive the referral, rather than waiting them to come into the clinic to be seen, because there's so many delays. The second thing is this treat to target approach, which is adjusting treatment relatively frequently, possibly every 3 months or so, to keep disease activity as low as possible. And that disease activity means a combination of symptoms of pain and swelling of the joints, objective signs of swelling, and pathological markers of inflammation like CRP, or sometimes imaging. And then the third useful strategy is, because there are so many treatment options now for rheumatoid arthritis, and because patients have to commit to a relatively long-term proposition here with treatment, that negotiating options and giving patients some involvement and engagement in the decision makings is helpful if you can, if it seems appropriate. And I quite like this Chinese proverb, because it sort of explains the treat to target approach being relatively agnostic with regards to how you get there. Many paths lead from the foot of the mountain, but at the peak we all gaze at the single bright moon. And so low disease activity is that single bright moon, but there are loads of different drugs and combinations of drugs that help us to get there. And there's quite a lot of individual variation, both amongst rheumatologists who are sort of making recommendations, but also the patients and their response to the drugs. The toxicity profile is different, and maybe pharmacogenomics may help us in the future. But at the moment, there's quite a lot of trial and error with trying a commonly used thing like methotrexate and then tweaking it every few months to find out the treatment that works. And in New Zealand, because of funding criteria for special authority via Pharmac, that also puts another kind of constraint on treatment options. But highly targeted anti-cytokine therapy, that is biologics, they've really revolutionised the management of rheumatoid arthritis. I was saying to Lucinda last night that we used to have a monthly combined orthopaedic rheumatology meeting where we would present our patients with damaged joints that needed surgical repair. Well, we don't need to have those meetings anymore because the frequency of patients needing orthopaedic surgery has just reduced markedly. So there were some pre-meeting questions about COVID and immunosuppression, which I'll just talk about very quickly. Basically, the bottom line is that most drugs are okay and don't, most of the drugs that we use are okay and don't predispose people to catching COVID or getting worse COVID if they do catch it, except for a couple, particularly rituximab, mycophenolate, and moderately high doses of prednisone. So those drugs have been shown to be associated with worse outcomes, and you need to take a bit more care of those patients probably, and a bit more enthusiasm for antiviral treatments like Paxlovid. So the other kind of thing is that methotrexate has been shown to reduce the effectiveness of COVID vaccination. So it's recommended that people skip 1 or 2 doses of methotrexate after each vaccine dose.
Well, just to clarify, is that all vaccinations or just the influenza and COVID?
Yeah, good question. Those are the
shingles?
Yeah, those are the only two. Those are the only two vaccine recommendations around that have been shown to be attenuated effectiveness with methotrexate. It may be true for other ones, but I'm not sure actually. For shingles, the problem is a bit different because the funded shingles vaccine is a live attenuated virus, and so it's kind of contraindicated to inject people who may be a bit immunosuppressed with viruses. Yeah.
And you don't tend to get a flare up if you withhold the methotrexate for 1 to 2 weeks?
Not generally, no.
Great, thank you.
Yeah, so rituximab is a particular problem, maybe a bit small print for generalists, but it is a headache for us as rheumatologists because it's a very long-term drug. It takes a year or so for it to be out of the system, and it not only interferes with the effectiveness of the vaccine, but it makes people worse if they catch COVID. There are some preventative antivirals coming along called Evusheld, which is a combination of 2 monoclonal antibodies, and that may be available to us soon, I believe. So I'll just, unless there are particular questions about COVID and rheumatology drugs, I'll move to the next slide.
No, yep, keep going, Will. Thank you. I can move on.
Yeah, so I've kind of listed the sorts of drugs that, or the sorts of treatment sequence we might use here, and I don't know that it's necessarily useful to go over this in detail.
All I would ask you with that, Will, is see your little 3-letter acronyms. You could just whip through what they are so that when someone's watching this afterwards, they know what they stand for.
So MTX is methotrexate. and hydroxychloroquine is HCQ, and that's a very useful adjuvant drug. It's not particularly effective on its own, but in combination with other DMARDs, hydroxychloroquine is quite helpful. Leflunomide is LEF, and SASP is cilazapirin. So those are the main four oral DMARDs: methotrexate, hydroxychloroquine, leflunomide, and sulfasalazine. And then there's then we get into biologics, and the funded ones in New Zealand are adalimumab or etanercept. That's a TNF inhibitor, and those are given by subcutaneous injection weekly in the case of etanercept, and every other week in the case of adalimumab. And then there are other MABs, other biologics. There's infliximab, rituximab, tocilizumab, and the newest one on the block is upadacitinib or Rinvoq, and that's a targeted synthetic DMARD that inhibits an enzyme, intracellular enzyme that is used for sort of signaling when a cytokine binds to the surface of the cell. So it prevents the action happening inside the cell. And in New Zealand, everything beyond sulfasalazine needs a special authority number, and you have to meet certain criteria for that. So there's quite a few barriers to those drugs, and in other countries, those agents would be used much earlier in the sequence. Okay, just a quick word about pregnancy and lactation, because a lot of young women get rheumatoid arthritis. And sometimes it gets better during pregnancy. Rheumatoid arthritis gets better during pregnancy, and treatment is not necessarily needed, but that doesn't happen all the time, but it often does. NSAIDs are generally okay until the third trimester, where it can interfere with the closure of the ductus arteriosus, so that's important to bear in mind. The main take-home message here is that methotrexate and leflunomide are contraindicated. Those are definitely shown to be teratogenic, and methotrexate is used to induce abortions in some places. So actually, just as a side note there, a lot of rheumatologists in the US, since the Supreme Court ruling on abortion, are getting nervous about prescribing methotrexate at all to women of childbearing age, because they could be accused of procuring an abortion.
Right.
Which is a kind of a curious twist. But cilazapirin and hydroxychloroquine are okay. And TNF inhibitors, the newest ones and the most effective drugs probably, are also okay in pregnancy, except you've just got to bear in mind that the antibody, these drugs do cross the placenta. So the neonate can be slightly immunosuppressed, which for a while, until they build up their own antibody repertoire, which can take 6 months or so. So there's a live attenuated vaccine, rotavirus, I think, that's given 6 and 12 weeks. That should be avoided if their mother has taken an anti-TNF right up until term. But if you stop it at about 20 weeks or 25 weeks or something, then it's okay. So pregnancy is generally quite manageable. I'll miss out this one. This is just ways of operationalizing the concept of low disease activity. And then this one, I think we're getting to the last slide, just to talk about typical side effects of the drugs that we use. And we do like to check blood tests periodically, usually monthly for the first 6 months and then 3 monthly, because most of the drugs can cause bone marrow suppression or hepatitis. So full blood count and liver tests are sort of mandatory. Creatinine can be useful, although it's not critical. And the CRP is often helpful in terms of disease activity monitoring. And the main concern with methotrexate is the risk of long-term liver fibrosis. That's what we kind of worry about the most with that drug. And that's why we get paranoid if we don't see liver tests periodically. The main problem with biologics is infection risk. Blood test monitoring is not so important for those drugs, but we do screening for latent TB particularly, and you just need to have a lower index or lower index of suspicion for treating infections with antibiotics in those patients. So the take-home messages are, this is the last slide, rheumatoid arthritis, it's usually easy to recognise, but not always. Treat early with a DMARD, adjust every 3 months to achieve low disease activity. There's lots of treatment options available. Unfortunately, none are perfect, but eventually we do find something that works for most people. Drug side effects are still a problem, generally speaking. Infection risk and treatment during pregnancy are challenges, and most DMARDs do require regular blood tests. Thank you very much.
Thank you, Will. Now, I'm one never to be afraid of asking a question, so probably why I do this job. But just in terms of your definition of high-dose steroids, in terms of the association with cleft palate, we do use a relative amount of prednisone. Is that the actual dose, and is it also the duration? Can you just...
Yeah, I'm not totally sure about that last bit. Certainly the dose, and possibly the timing of the prednisone during the pregnancy too.
What's your definition of high dose? 60, 40?
40, yeah.
40, okay. And then the second one was yesterday we were talking about methotrexate and its mechanism of action and how most of the reasons for stopping or people not tolerating the drug is because of its anti-folate action and just around the folic acid regimes and things.
Right. Yes. So methotrexate is a folate antagonist, and that's certainly the mechanism of its action in cancer chemotherapy. But in rheumatoid arthritis, it doesn't seem to be quite so important. It does some other things as well. But a lot of the side effects are mediated by folate inhibition, and so supplemental folate can reduce those side effects, particularly mouth ulcers and nausea, and sometimes liver abnormalities. And the standard sort of regime is 1 5 milligram tablet a week, but there are lots of other approaches, and people have, there's no kind of very good science or trials around this, I think, but because it's just a vitamin B tablet and you can't really overdose particularly on folate, taking more of it can help keep people on methotrexate when you want them to stay on it, because it's working quite well for their arthritis, but they just get a bit of nausea for a day or two after taking it, or their liver tests are a bit of a worry. So increasing it to the folate to every second day, or sometimes every day apart from the day that they take methotrexate, is not uncommonly utilised in order to keep them going.
And it was good in my mind to realise that that didn't actually negatively impact on its effectiveness as a treatment for RA, because that was what I had a concern around that in terms of.
Yeah, and that sort of underlies that thought, underlies the sort of the reason why it's avoided on the day that they take methotrexate. I actually think that that's probably a bit of a myth as well. We just don't know exactly how much and when, and things have just kind of arisen from practice. But that's the convention, is not to take it on the day of methotrexate because of that theoretical risk that it might interfere with this activity, but it probably doesn't.
Yep. Okay, great. Thank you, Will. I'm going to hand over to you, Gary, because I do think someone snuck one in at the bottom, which is brilliant. We're happy with that. Do you want me to ask?
I think Gary needs to unmute himself.
Sorry about that. There's a question there from Alex, and it's around any tips for differentiating RA from OA and hands, finger joints, and any adjuncts to medications for this, I presume for both RA or OA.
Right, yeah, so OA typically affects the DIP joints, and rheumatoid arthritis does. And also the other characteristic joint that OA affects is the that it's not really so dominating. So pattern of joint involvement is quite important. Similarly, MCP joint involvement is uncommon in OA, but very common in rheumatoid arthritis. So pattern of joint involvement, and then the nature of the swelling. So soft tissue swelling is the rule, particularly in early rheumatoid arthritis, but bony swelling is the rule for osteoarthritis. And so you get these Hibidin nodules, which are those little pea-like bony protuberances on DIP joints, and Bouchard nodules, which are similar but on the PIP joints. And those are pretty typical of osteoarthritis. So yeah, the duration of morning stiffness is usually not quite so long in osteoarthritis. And you don't get a raised CRP, and obviously they're not seropositive for rheumatoid factor and CCP, but mostly it can be distinguished on just looking at their hands. What was the other part of that? Adjuvant treatments, is that for yeah, so osteoarthritis, that's another kind of couple of hours talk in itself. There actually isn't, well, in a way it is pretty quick answer. There's not that many effective treatments for osteoarthritis, unfortunately, from a sort of biological point of view. There's no interventions that I'm aware of that alter the natural history of osteoarthritis. So it's palliative essentially, and trying to maintain function. And there are lots of kind of things around that with splints and orthoses and gadgets and aids and pacing and then from a sort of a symptomatic point of view, different kinds of gels and nutraceuticals and CBD oil, you name it, people have tried it for osteoarthritis because there basically isn't anything that's, overwhelmingly effective. I have to say I'm a little bit pessimistic when it comes to treatment for osteoarthritis.
You can certainly, though, with OA, I've certainly changed my mental algorithm around it in terms of utilising it as a wear and repair, and that, depending on the joint, not so much in the hands, but in terms of weight management and mobility, and motion is lotion. So actually actively using the joint and the cartilage within the joint, being able to continue to produce its synovial fluid and lube itself up and things, is what I've read recently. And I'm more of an optimist, maybe.
Yeah, no, look, I think that you're quite right, Lucinda, and there is this kind of unhelpful concept of osteoarthritis as being due to joints wearing out, and so that communicates to the patient, well, I should stop doing things so that that I don't wear out so fast. But movement is healthy for joints and does improve their nutrition. And most of the underlying reason for osteoarthritis is genetic, and sometimes injury. So you can, if you damage a joint, then it's more prone to developing osteoarthritis lately, particularly chondral injuries. But yeah. So I think what you say is right. Movement is good, and we should be encouraging that.
Well, that is great. Thank you, Will. Thank you, Gary. So thank you, Will, with our utmost appreciation for your time organising and presenting and answering all our questions this evening. I certainly know that my knowledge has been refreshed, updated and clarified around inflammatory arthropathy, and I think that's going to have a threefold benefit for my own personal clinical skills, my patients' care, and also for the sanity of all the rheumatologists out there. So I would like to say thank you very much, and also thank you to everyone for attending. Gary has put up the evaluation form for you, so if you would like, I would love everyone to complete the evaluation form, but if you would like me to load up CME points for you, put your medical council number in there. Thank you very much.